Here we have another Glenn, another clinician scientist here. Did a lot of his training in the United Kingdom at University of Leeds, where he eventually, after his surgical training, went on to do a postgraduate research degree at the Cancer Research of the UK. And at that time, in 2006, he was looking to identify markers in bile for liver malignancy. Subsequently, he then went on to Birmingham and trained in the transplantation, presumably. He presented widely. He was also given a grant by the Royal College of Surgeons of England to pursue a fellowship in the investigation of molecular biology of HCC. At NUH, he returned to NUH, continued to do a lot of work in HPB, but also continued to pursue his clinical and I think translational research. His clinical research resulted in him receiving the Presidential Award of the IHPBA Association in 2014. So it gives me great pleasure to now hear from him his take on personalized perioperative care for pancreatic cancer. Glenn?
Thank you very much for all that, Melissa. And it's a tough act to follow Prof. Gobuncher after that excellent talk, and to be just before lunch as well. So if you bear with me a little while and talk about the pancreas. Thank you very much for everybody for your attention, and for the hosts and Prof. Jimmy for this honor of standing here and sharing with you a personalized approach in pancreatic cancer. So I think it's important to first, given the mixed audience, to have a look at the incidence of what's happening worldwide with this disease. So on here you can see data from Australia, France, Taiwan, China, and the UK that shows that really in the last 5 to 10 years there's been a huge rise and uptick in this disease. In this chart you can see that recently published about 4 years ago, divided by all the continents first shown on your left, and representative countries from those continents right next to it, the incidence for men and for women, and the rise in that incidence. So a fall will be to the left, and a rise will be to the right of the graph. And you see that actually Singapore is in the top 5 for the rising incidence worldwide in men and in women in pancreas cancer. What's worse is if you project the cancer deaths associated with it. This is data from the Pancreas Cancer Action Network. You can see that there's a projected fall in most cancers, but the cancer-associated deaths are predicted to rise in the next 10 years in this disease. So dismal with the rising incidence. A brief touch on the history. So it was actually an orthopedic surgeon that braved the endeavor to start operating on the pancreas, but it really was Alan Oldfather Whipple, who from Columbia University, that made it famous, initially describing a 2-stage operation and then the further modifications we know today. But by the mid-20th century, we'd seen really high mortalities associated with this disease, nearly 50 and up to 80% following surgery. Some lawmakers were actually calling on a law to make this operation illegal at the time. Fortunately, things have changed. So what's changed? Inpatient mortality has improved even within my 20-year career operating on the pancreas. In NUH, there's been less than 5% inpatient mortality, and the median length of stay is 10 days for our Whipple's patients. And this is largely through a number of different things I want to touch upon, which is an importance of hospital volume and postoperative outcome, tracking of that risk stratification, defining resectability, systemic therapy, and minimally invasive surgery, and I'll touch upon these shortly. So first, when we look at volume and its relationship with outcome, this is a landmark study published and led by Mark Baselink in the Amsterdam group. They looked at 3,400 Whipples over the period of 8 years in a multi-center Dutch study, and they looked at the outcomes and they adjusted this for confounders between the different centers. And when they looked at the volume and outcome relationships, they found that actually, indeed, the number of operations performed in the centers affected outcomes, such that in these 2 tables, you see the independent prediction or the multivariate logistic regression analysis on the far right for increasing number of operations on, in table 2, the 90-day mortality, and more so, and interestingly, on overall survival of the patient. So there was a significantly better 90-day and overall survival for centers that were doing more than 40 pancreaticoduodenectomies a year. There's a big mantra in medicine when you get into medicine that often lots of us remember, that you eat when you can, sleep when you can, and don't mess with the pancreas. And that's largely because of the fistula associated with operating on the pancreas. So clinically relevant pancreatic fistula remains the source of significant morbidity, and it can be and published as high as 20%. So prediction of fistula risk before the operation can better stratify the operative risk, allows you to discuss the risk with particularly high-risk patients. It can perhaps inform the need for drains, hospital monitoring, and especially as surgeons, it increases your threshold for concern about investigation or intervention with the patient. There are multiple studies that have looked at this, and there are many risk factors that have been described, but perhaps the most established one is this, published in JACS about 8 years ago by Chuck Vollmer's team in the States. And they very simply looked at 4 factors: the firmness of the gland, the size of the pancreatic duct, the amount of bleeding intraoperatively, and the type of pathology for the pancreas. With that, they assigned a score shown in the bottom right, and the summation of that score has been validated in multiple studies, predicts your likelihood of leaking after Whipple's Pancreaticoduodenectomy. Moving on to the resection. Really thinking now on the aim that we are trying to achieve preoperatively, thinking about this, what we are trying to achieve in pancreatic surgery is to reduce as much as possible the number of aborted or non-therapeutic or R1 or R2 surgical explorations without denying potentially curative resections to any patient who may benefit from it. And I think that summarizes what we aim to do as pancreatic surgeons the best. A lot on this slide, but the first thing we want to address is resectability, and this really has been addressed very nicely by multiple guidelines worldwide. So you see on this slide AHPBA, SSO, SSAT, MDACC, and NCCN. In short, to summarize from here, the NCCN guidelines has widely been accepted as the one that provides the highest R0 rate for surgeons, and that's what's summarized here in this chart. I don't want to go through all of it, but broadly speaking, preoperatively, we're considering the involvement of the vein and the artery. So if you look at the top, resectability of the vein is only if there's less than 180-degree involvement of the portal vein and the artery is clear. Borderline resectability is when there's more than 180-degree involvement of the portal vein with an option for reconstruction, and most of us operating on the pancreas will include the first jejunal branch, and so we would take that branch and quite safely. And for the artery, for borderline resectable, is up to 180-degree effacement of the artery. Why is that important? This is an important consideration preoperatively. In borderline resectable patients, these patients should have an EUS and a biopsy, given neoadjuvant chemotherapy, and restaged for their response prior to consideration of surgery. And now this is leading nicely into neoadjuvant therapy. Very briefly, a lot of us know this. The standard of care for neoadjuvant therapy in pancreas cancer is FOLFIRINOX plus minus radiotherapy, or gem-paclitaxel or gem-cisplatin plus minus chemoradiotherapy. The decision here is crucial, and we'll come back to this, is based on the performance status of the patient. So if you're a good performer, per se, you'd get FOLFIRINOX, whereas a slightly poorer performer would get gem-paclitaxel or gem-cis. Now, what about the resectable patients? Are we going to give them neoadjuvant chemotherapy? There are a number of trials running, and in fact, in ASCO last year, abstracts published with one of them reading out, and it's looking like high-risk features like a high CA19-9, size of the tumor, bulky nodes, are going to start pushing resectable patients towards neoadjuvant chemotherapy. The take-home point, which I'll come back to here, is it's still looking like it is morphological features and performance status and not biology per se that is making that decision. So this is just a quick example. On the left, a patient that you can see the disease all the way around the portal vein and all the way around the artery, and after some FOLFIRINOX, you can see that peel away, and surgically it's lovely to see and lovely to operate on because these planes open really nicely. So Whipple's procedure, a lot of us know what it is. This is the extraction of duodenum, head of pancreas, and bile duct. And after the specimen's taken out, great care must be taken to do a proper lymphadenectomy to clear the anatomy like this, so that you can see in this patient of mine where there's a low tick of the right hepatic artery, all the lymph nodes are taken out and cleared, and you expose the portal vein, the IVC, right hepatic, left hepatic arteries, and pancreas. But important to consider preoperatively is the approaches to the SMA, and really this work wouldn't be complete without mentioning Professor Markus Buchler from Heidelberg that's described most of these techniques as well. So the advantage of this is that it allows for the resectability of the cancer to be checked before the division of the uncinate. What I mean by this, for the non-surgeons in the room, is often one approach is to go anteriorly and start dividing the uncinate from above, and then find for an uncinate tumor that the tumor is abutting the SMA, and you end up leaving a resection margin that's positive there because you're committed to the operation already. The way to avoid that is to do an SMA first approach, so dissect the tumor off the artery first. But of course, over-dissection can lead to diarrhea, and it can be technically challenging. So these are three different examples of this. On the top right is the standard of what you do, where you expose the right hepatic artery, and here you can see, the right side of the SMA, and here you can see a patient of mine where the common hepatic artery actually arose from the SMA. The anterior approach is found at the base of the mesentery under the transverse mesocolon, and an example of that. And the inferior approach is with a full cauterization, as we all know, just as the SMA comes off the aorta at the left renal vein. So there have been many advances in surgery. Certainly within the realms of transplant surgery, we replace portal veins and do portal anastomosis regularly. So portal vein resections, artery first resections have you seen. And I touched this briefly, but certainly distal pancreatectomies should be performed lap. I think in the last 3 years, certainly every case in NUH has been performed lap as a resection at the outset. But the big question is, what about minimally invasive surgery for a Whipple's, a Pancreaticoduodenectomy? This was a very important study published by the Dutch group, again, Mark Baseling's group, and this was in 2019, and this is the Leopard 2 trial, a randomized control trial comparing lap versus open for Whipple's Pancreaticoduodenectomy. All surgeons must have done at least 50 Whipples and at least 20 laps before they could be enrolled into doing this trial. 2 surgeons are doing the operation together at the same time. There were predicted to be 50 patients in each arm, but the trial was actually terminated early because of safety concerns for inpatient mortality in the lap group. Since then, the last 2 years, there have been 3 further trials. These are large centers performing laparoscopic Whipple's pancreaticoduodenectomies and comparing lap versus open, and 1 meta-analysis. So far, we see no real difference. There is differences in blood loss, which is better in lap, and operative times, which is better in open. 2 trials show a slightly shorter length of stay in the lap group, 1 a slightly longer length of stay, but overall complication 90-day mortality remains similar. The French authorities have actually stopped lap pancreaticoduodenectomies, but promotes laparoscopic distal pancreatectomies. I think as a whole, the community feel that this is certainly something that we are adopting. Involves concerted growth within individual centers of doing so, picking the right patients based on your center volume, based on surgical expertise, based on types of tumors, as well as the technologies available. But perhaps this is an extension too far. This published in the last few months. This is a lap pancreatic resection with an extraction of the specimen through the uterus and the vagina, and that's been done with the rectum as well, and maybe just a bit too far within the context of this disease. But what has not changed, and this is a really important figure, this figure shows the change in 5-year survival of all cancers right at the top over the last 40 years. So what it was 40 years ago to what it is now. And if you follow that figure and your eyes stick all the way to the bottom of that, you'll see that the first thing is pancreas cancer has the lowest survival of all those cancers. And more importantly, if you look at the size of the error, over the last 40 years, there's only been a 5% change in overall survival. So we've improved all our systemic therapy, we've improved all our surgery, we've improved all our perioperative outcomes and techniques, etc., but we're doing very little to the survival of these patients. And certainly as a pancreatic surgeon, it's disheartening to keep seeing those patients that come back and recur shortly after surgery. So let's go back to this aim again and start to think about what we can change. Surgery has defined what we should and shouldn't abort, so resectability and R1 and R2. But now we think about what we'll be doing without denying potentially curative resections of patients that may benefit from it. So biology and patient fitness is coming to play. So I argue that perhaps of most cancers, in pancreas cancer, the interplay of this tripartite equation between biology, resectability, and fitness is important, because you can see that you could give somebody chemotherapy, you may or may not affect biology, you certainly will affect fitness, and that may affect outcome of the patient with an unknown equation. So we started this, a precision approach at looking at pancreatic cancer to personalize systemic treatment in the perioperative period, doing so with patient-derived organoids, AI, and mass spectrometry, which I'll come to. The overall hypothesis is to create a proteogenomic landscape of patient-derived models in pancreatic cancer with the ultimate aim to reveal novel biomarkers to guide therapy. How do we do it? We mostly aim at doing this at EUS biopsies, and the reason I'm saying this is because we want to do something before they get to surgery. We don't want to take the surgical specimen and affect adjuvant therapy. It has importance, but we're trying to see how we can affect the cure better. So we get EUS biopsies, and we developed three different aims. The first aim is we started this about 2 years ago to generate patient-derived organoids, which we then xenographed into mice. The second is to create genomic and transcriptomic data, which we ultimately hope to create, number 3, therapeutic biomarkers for discovery by quantitative proteomics. We do this by EUS biopsy, as I mentioned right here at the top. This is work done by Shinling, who's a postdoc at my lab, and Claire, who's a PhD student. And this is an example of the patients that we have. We've got about 12 lines growing. We're able to then absolutely validate this because pancreas cancer is G12 mutant, KRAS mutant. We are then able to do IC50 for various drugs to then create a sensitivity based on single agent of chemotherapy, and these are examples of what we have xenografted, as well as normal and fibroblasts. Then we want to know which combination of chemotherapy works best. So using the organoids, we're able to use an AI-based system to be able to miniaturize the way and shorten the time by which we can predict that combination. I don't particularly want to go into it, and happy to answer this in questions, but this is work done by Ed Chow and worked in collaboration with Dr. Yong Wei Ping and Dr. Chi Cheng Yan here at NCIS. And in short, we are then able to see how different drugs can work in synergy to reduce cell viability for that patient. However, the generation of the organoids take 2 to 3 months to happen, so we ask, can early proteomic biomarkers predict chemosensitivity? We do that by taking the organoids, taking the conditioned media untreated and looking at the proteomics, and then looking at responders versus non-responders and their proteomics. So long before they've matured into the 3 millions, we're looking at small populations of cells. I'm very pleased to say this bottom right volcano plot is just out in the last 2 months. So if you take our organoids and you look at the responders to FOLFIRINOX versus non-responders, and you separate out their proteomics, you see a huge number of protein signatures that will be up or down regulated as biomarkers for response to FOLFIRINOX. So potentially really important in treatment of patients preoperatively. I'd be amiss not to mention a few other considerations in our collaborations with pancreas cancer. KRAS has long been undruggable, and through in silico work done in A-star by Charlie Johannes, they've managed to find a cyclic peptide that is able to drug KRAS, in particular G12D. Now, Charlie got in touch because obviously pancreas cancer is heavily KRAS dependent, and so he says, can we work together? And it's looking really exciting as this cyclic peptide is able to drug KRAS, certainly in an ex vivo model. In the bottom left, you see work that has been covered extensively by Prof. Bunche about neoantigens and harvesting the immune system to be able to treat cancer. So we are trying to discover these neoantigens in what has long been a cold tumor, pancreas cancer, and we do so with simple immunoprecipitation and proteomics. So we're taking MHC-expressing patient-derived organoids, separating it on an elution column, and doing shotgun proteomics to it. Finally, if you do find these drugs and peptides, we've heard all about vaccines. We're working with Mindler in pharmacology, who's using red blood cell-derived extravesicular vesicles, exosomes, to be able to package these peptides and drugs to be able to target the cancer better. And I finally want to mention a collaboration with Raghav and MSD as well, where we would be amiss if we don't consider the microenvironment in pancreas cancer. So our organoids are being co-cultured with cancer-associated fibroblasts in the hope of developing novel therapies. So in summary, pancreas cancer has a rapidly rising incidence internationally. It's crucial to have a multidisciplinary approach to focus on its care. There's been much improvement in perioperative outcomes in this surgery, but there's been minimal improvement in overall survival, sadly. So given the complex nature of the surgery, it's crucial to balance the targeting of this biology, optimizing the fitness of the patient, and to have this sort of comprehensive care approach. Much effort is needed in predicting this biology and precision surgical oncology and improving its survival. It leaves me to thank all my clinical collaborators in surgery, gastropathology, and oncology, all the people in my lab, and I haven't mentioned our coordinator, Ivy, and all that. I'm supported by Brooker Deltonic in a research collaboration agreement for mass spectrometry, and in the School of Pharmacology, Ed Chow and Mindler, who I've mentioned, and the collaborators in A-STAR. We couldn't do this without our teams. These are our residents, administrators, transplant coordinators, and it went this long before COVID, obviously, with the lack of social distancing, that's obvious. And to our international friends online and colleagues who have joined us today, I hope this clears up soon, and we'll be really happy to welcome you back to Singapore soon. Thank you very much.
Glenn, thank you very much for the talk. I think it's exciting, the work that you're doing, and honestly, while there are really nice surgical pictures, I do think that pancreatic cancer cannot be cured in the operating theater. My gut feel is that pancreatic cancer is a little bit like breast cancer, where there's probably micrometastasis in most patients by the time they're diagnosed, and we're not catching it, ahead of time. So systemic therapy, one way or the other, be it vaccines or immunotherapy or something else, would probably have to be the way to go. If you had to put your money on one thing, I mean, you've got quite a lot of projects going on. If you had to put your money on one thing that you think it would be a game changer in treatment of pancreatic cancer, what would it be?
So your question, Melissa, is kind of two-pronged, because the first question was we can't cure cancer, but the second part of the question, how do you cure cancer?
Oh, no.
So I agree.
Cure is a huge
so I
thing,
agree
yeah.
that I totally on board with this. That we probably are not curing patients from pancreatic cancer. The data shows that, but we mustn't forget that without treatment, survival somewhere between 3 and 6 months. With it's 30% at about 3 years is what is the best. 30 to 40% with more forms of chemotherapy. So if you've got pancreas cancer, if your question is what's going to be a game changer, I think that stuff that Prof. Bunche was just talking about, and some of the stuff that we are working with collaborators on, harvesting the codependence of the cancer-associated fibroblasts and using the immune cells to first target that. And then what we talked about, synergy with chemotherapy, delivering the appropriate chemotherapy to the cancer once you can tackle issues with the microenvironment, may have real potential change to this disease. But coming back to your first point, which I agree with you on, the game changer is going to be in the pancreatic cyst domain. It is predicting who's going to get pancreas cancer and preventing those patients or operating on those patients before they get pancreas cancer, or getting it early enough, and then you'll see survival change. All the other work that we do, once the cancer is actually there, is how best you target that microenvironment, target the tumor, and then do excellent surgery on top of that. That's what I think would happen.
So doing Whipples is one of my favorite operations, I would say. I don't know about, you see, when we talk about trying to diagnose patients or prevent, well, not prevent, but pick up pancreatic cancer early enough, then, you know, we end up talking about public health issues and really cost effectiveness studies about screening for patients for fairly rare type cancers compared to, say, colorectal or breast. I wonder if, I was asking about game changer mostly because I guess I do think harvesting the tumor and understanding the tumor microenvironment and hopefully finding a suitable target will be the way to go. I mean, I don't know if we'll find something in the same way that immunotherapy has done for melanoma and really been that game changer in the past 5 years, but I guess, you know, if I had to put money in something like that, it would be systemic therapy much more than I guess aggressive surgical therapy.
Prof. Jimmy So.
Thanks, Chairperson. Yeah, Glenn, a fascinating talk. If I just follow for Melissa's comment that for esophageal cancers, is no longer using adjuvant therapy. All systemic therapy are given before surgery. And this is because that adjuvant therapy is harder to tolerate. And this is, we know the failure is actually a systemic failure rather than a local failure. So do you foresee that actually for pancreatic cancer, even for resectable pancreatic cancer, everyone should have chemotherapy first before you touch, before a Whipple operation?
Yeah, thanks for the question, Prof. And I think just unpicking two elements of that, and it's to do with the fitness and the surgery. Much like yourself, morbidity in pancreas surgery is high, but also slightly different to yourself is some of the chemotherapy agents, especially oxaliplatin, changes the actual inflammatory process in the pancreas. The very organ you're operating on is different post-chemotherapy and becomes harder to operate on. You're stenting these patients and then exposing their bile to the GI tract. So the complication rate now increases with this. So if you're going to give somebody chemotherapy, and this is really where I started with this, is if you're going to give somebody chemotherapy, it'd be best to know that you're going to make a biological difference so that the cost of the complications that arises as a result of that is worth that chemotherapy that you're giving. And that's why that stuff with predicting early predictions of FOLFIRINOX particularly excites us.
Thank you very much, Dr. Bonney, for that wonderful talk. You talked about surgical resection and then going into molecular precision with the organoid models. How scalable are these models and how reflective are they actually of a patient outcome? And for example, in terms of the range of drugs that you test on these organoid models, how do you rationalize like maybe a set of drugs that may be most effective?
Thanks, Joshua. A few different things to unpick there. The first thing's how scalable. Answer, not very scalable. So if you're talking about efficiency to grow, we do it actually very well from an US biopsy to consider how small it is. The success rate is 60%. But if you give us a surgical specimen in the region of 90 to 95%, it will grow. The next thing about scalability is obviously economics and the funding of maintaining those organoids. To get it to immortalized stage, about 3 or 4 passages, it is quite expensive, and pancreas cancer is a small, low-budget cancer at the moment. So that's difficult. The next thing is to say, is this now scalable on a wide population? Like many centers are now going to start growing organoids because it's so important in the patient algorithm. Answer is no. I think because organoids in themselves are not representative of the tumor as a whole. It's a good place to start with to understand the tumor, and pancreas cancer is a great place because you know that the organoids are growing because they're KRAS mutant and they're xenografted to have adenocarcinoma. So you're okay to do that. But actually it's an ex vivo attempt to try and unpick the microenvironment, co-cultures, etc., in an organ that's hugely inaccessible, whether it's gastric or colorectal cancer, etc. You can access these tumors. The pancreas is not accessible in this way, and that's why it is important to do this work, but I don't think it is a scalable approach.
How closely do the outcomes on organoid treatment actually reflect patient response to the same drugs?
So for us, we haven't got to the trials of doing that, but published by Ed Chow, who I was mentioned. He's done so in with Weiju actually, and is outstanding results. Published in Science Translational Medicine about 4 years ago. So using an AI-based platform to shorten the number of tests required, resolving it by a parabolic equation, you're able to then say which combinations best work for the patient, whether it's synergistic or antagonistic, etc. And you can do that for about 12 drugs.
See, thank you. Really fascinating work there, Glenn. Was there a question from Buncha? Yes.
Thanks, Bonney. Glenn, for that wonderful talk. I guess for pancreatic cancer, the main impact would be to prevent the tumor from developing, right?
Yes.
So is there a reason why the incidence is increasing? Is it because of diet? Is it because of the contents of diet? How is it related to the microbiome?
So it's a simple answer, Prof, is I've looked into this and it's not fully understood why yet. A number of things is long thought smoking is a cause for it. Smoking actually has kind of plateaued worldwide, yet the numbers are skyrocketing. But if you look at the curves of pancreas cancer and type 2 diabetes and obesity, they sort of mimic each other. So it is inferring that it's likely to be diet and lifestyle that is doing this. But I still can't understand then why is Singapore, and it's really palpable. We're doing 1 to 2 pancreatic resections a week now. And that's very different to what it was when I first got here about 4 or 5 years ago. So why that's happening, it may be microbiome, it might be diet, etc., but it's not clear just yet.
One question, why is it related to KRAS?
I think safe to say, Prof, you may know that answer better than I do.
All right, if there are no other burning questions, I'd like to... Joshua, anything else you want to add?
No, I think it's been a really fantastic few sessions. We looked all the way from the use of poliovirus, and then after that BCG, and now really organoids and pushing the boundaries of surgical resection. So I think it's been a really fantastic session. We want to thank all our speakers for their wonderful talks and for their time.